All right, well, hello everyone. I'm KJ Hansmann. I am a third year in the Primary Care Research Fellowship, Family Medicine Doctor at the Northeast Clinic. And as part of my fellowship, I'm pursuing a PhD in population health. So today I'm going to be sharing some of the progress that I've been making on developing my dissertation proposal, particularly looking at a secondary analysis of data from the National Health and Aging Trends Study, looking at neighborhood walkability and social isolation for older adults who are experiencing driving retirement. So what is driving retirement? Driving retirement refers to the transition that older adults make when they stop driving, and this might be due to declines in their physical function or their cognitive function. Driving cessation, a more general term, is something that can happen across the life course, but driving retirement is a normal part of life. Many of us will face a time where we might have to give up driving due to age-related conditions. This is relevant to quite a few people. In 2018, there were more than 45 million licensed drivers older than 65 in the United States, and this was a 60% increase from 2000. These numbers are growing, they continue to grow, and driving remains the preferred mode of travel for older adults in the United States, which is particularly important given that estimates show us that older adults are expected to live 6 to 10 years on average after driving retirement. So what will happen when they no longer have their preferred mode of travel? How will they get around their communities to the places that they need to go for their health and well-being? Well, given that question, it might not be surprising to see that driving retirement is associated with several negative health outcomes. So it's associated with decreases in social interaction, increased depression, declines in physical function, increased rates of cognitive decline, and increased risk for mortality. But not everyone's at the same risk for driving retirement and these negative health outcomes associated with it. Studies have shown that driving retirement is associated with gender, wealth, race, and personal health status, including frailty. And so with these individual characteristics, women, people with less accumulated wealth, and racial and ethnic minorities have a higher odds of driving retirement than their male, rich, white counterparts. Conversely, in terms of community characteristics, older adults living in rural areas actually have a lower odds of driving retirement. And this starts to paint a picture of how people's community contexts are going to inform their decision to stop driving. I'll also acknowledge that driving retirement is sometimes a voluntary process, and sometimes it's an involuntary process. So what might drive or mediate this relationship between driving retirement and these adverse health outcomes? Well, the primary mediator that I'm going to focus on for my discussion today is community mobility. So again, this idea of how people are able to travel around their community to the places that they need to go for their health and well-being. And this is also going to be moderated by individual characteristics, so an individual's personal coping ability and their social supports, as well as their community characteristics. So what is the transportation infrastructure and services in the community where they live? So starting to look at this concept map, one of the things that's really come out to me in my reading in this literature is that this is getting at social conditions that are fundamental causes of disease and health inequities. So I'm not hypothesizing that there's a biological difference based on gender or race or the amount of wealth that people accumulate over their lifetime that is driving this change in relationship with driving retirement, but rather that upstream social determinants of health are determining these downstream events when people retire from driving and their health trajectories after that life transition. And without addressing these upstream social determinants of health, we're going to continue to see adverse health outcomes and health inequities that persist when we try to intervene at other points along the pathway. So with that in mind, the objectives that I'm going to discuss today are examining the association between community transportation alternatives to driving and the timing of driving retirement, and examining the moderating effect of these community transportation alternatives on social isolation after driving retirement. I'm proposing to conduct a retrospective cohort study using National Health and Aging Trends Study data. This is a nationally representative study, including a sample of Medicare beneficiaries ages 65 and older. It's based on annual in-person interviews that have been conducted starting in 2011, and it includes publicly available data about health behaviors, health attitudes, and health outcomes, as well as restricted data with geographic information to the census tract level. And I'm proposing to use that restricted information so that I can incorporate community context information about walkability using the National Walkability Index from the Environmental Protection Agency. The National Walkability Index is a national data set of walkability scores for every census block group in the United States. So it's based on intersection density, how close are intersections to each other, essentially how short are the blocks that people are going to be walking, What's the proximity to transit stops in that community? So it does have some information about public transit as well. And the diversity of land uses. So are there places to walk to? And how might that inform people's choices about whether or not they're going to walk in that census block group? This map on the bottom right shows the National Walkability Index across the United States for every census block group. Dark orange or yellow is the least walkable, and it's based on quartiles here. So there's yellow, light green, and dark green being the most walkable. And so looking at this map, you don't see a lot of green, and that's because walkable areas are predominantly in more urban or metropolitan areas. So this is zoomed in to Madison, which we're all at least somewhat familiar with. We see some dark green, some light green, and in the larger Madison watershed that our clinics here in the Department of Family Medicine serve, we see primarily yellow and orange with a few pockets of green in some of these smaller communities. So getting back to the objectives that I described proposing to study, first is looking at the association between neighborhood walkability and driving retirement. So my hypothesis here would be that living in a less walkable census tract will be associated with a lower odds of driving retirement and driving reduction during the study period. And I propose to study this using a mixed effects logistic regression model where the key outcome will be change in driving status, so driving retirement or driving reduction, which the National Health and Aging Trend Study it has questions about asking whether drivers restrict their behavior around driving in bad weather, driving at night, driving on highways, etc. And the explanatory variable here being the National Walkability Index for the participant census tract, which is a slightly larger area than the census block group. The covariates that I propose to include are based off of the concept map that I showed at the beginning. So participant covariance would be gender, race and ethnicity, the highest level of education achieved, family income at baseline, and then variables that might change with time, so the participant's age and whether or not they're living alone. And then area level covariates using the restricted geographic data, looking at the census tract urbanicity, so is it a rural or urban area, and is that collinear with the walkability? There's obviously some overlap, but is it a perfect overlap? And the neighborhood disadvantage of the census tract. The second objective I described then is looking at social isolation after driving retirement. So driving retirement has been associated in previous studies with social isolation, and that's at least partially mediated by community mobility. Other factors on the bottom arrow there might be sense of independence, sense of identity that comes with driving cessation. And what I'm proposing to study here is the moderating effect of neighborhood walkability. I'm also interested in studying more distal health outcomes like depression and cognitive decline as secondary outcomes. So the hypothesis here would be that adults living in less walkable census tracts will have a greater odds of worsening social isolation in the years after driving retirement. And again, I used a mixed effects logistic regression model to look at the primary outcome of social isolation based on a categorical score from questions about the participants' formal and informal social activities, and secondary outcomes of depression and cognitive decline, with the explanatory variable here being the participant's driving status. So have they been a continuous or current driver through the longitudinal interviews? Have they stopped driving since the baseline interview? Have they reduced their driving behavior since the baseline interview? And also some of the participants were non-drivers at baseline, so they're never drivers. The moderator effect here that I'm interested in studying is neighborhood walkability. So some of the key limitations that I'd like to take some time to talk about are about how well this National Walkability Index is going to get at studying the constructs that I'm interested in. So for starters, is the National Walkability Index applicable to how older adults make decisions about what is or isn't walkable for their communities, particularly older adults who are experiencing driving retirement and might be experiencing declines in physical function or cognitive status? This has not been well studied previously, and a lot of data that we use to gather around national travel behavior is based on people who are working ages and how they travel to work. And so the distance between blocks, the distance to transit stops, and the types of destinations that older adults might be going to may be different. The census tract is also the unit of measurement that I will have available to me from the data I'm proposing to use. It's not ideally going to represent the participant's sense of community or neighborhood. It might not be the best way to represent what their transportation alternatives are or how they perceive them, because that's going to vary from person to person. And really what this gets down to then is what is the lived experience of the participants in this study and in these communities, and what other transportation alternatives might they be considering when they're making the decision to stop driving, and when they're thinking about engaging in social activities once they have stopped driving that might not be measured by the National Walkability Index. So these could be volunteer ride services, rideshare services, ride services specific to older adults. So some of my next steps will be to try to think of ways to address some of these limitations. So in addition to the analyses that I proposed, once I have access to the restricted geographic data, I'm also hoping to conduct a preliminary exploration of the association between walking behavior and the National Walkability Index for older adults to see if this seems like a valid construct for them. Beyond that, I also hope to include some of the subjective data that is included in the National Health and Aging Trend Study, so looking at the measures of perceived neighborhood disorder and social cohesion. I almost said it was the participants' measure, but in fact, in the National Health and Aging Trend Study, it's the interviewers' comments on perceived neighborhood disorder and social cohesion. And so that will be another limitation when thinking about what that actually means about how the participant is making these decisions about their driving and mobility behavior. And then from there, I'm planning to start to engage in qualitative methods so that I can participate in stakeholder engagement to help inform the framework that I'm using and other researchers can use to evaluate these community characteristics that are so important to community mobility after driving retirement. The real goal here is to develop interventions to address these disparities in terms of how transportation resources have been distributed throughout our society. Issues like systemic racism and other systems of oppression have meant that some communities have more resources than others, and because we've not had enough anti-racist policies, we've not undone that work in our society. So one of the stakeholders that I'm working with at this time is the National Aging and Disability Transportation Center, starting to connect with them to try to find other community partners that might be great for developing pilot and feasibility studies going forward. Because my long-term objective is to investigate community-driven solutions to support ongoing mobility and promote physical and mental well-being for older adults, particularly older adults living with Alzheimer's disease and related dementias, because conversations about driving retirement are really central to the long-term health and well-being of these patients. So thinking about driving retirement in the long term. I'd like to thank my primary research mentor, Amy Kind, and my mentor team for my dissertation, as well as the many people that I've been collaborating with in our department, getting advice from across the university, and of course my co-fellows, the program directors, associate program directors, and Christina for helping to organize everything that we do here in the Primary Care Research Fellowship. And I'm excited to take your questions.
Yeah, so this just is on target. First of all, it's great work. I love it. It's on target with a patient I saw last week and I've been working very closely with over the last few years, who has cognitive issues that have made him not a driver and have actually taken him from a walkable neighborhood to live in an area, in an assisted living place. And it turns out that in our community, research rich as it is, there's a virtually 100% correlation between where assisted living facilities are located and non-walkability. And that's because of land values and other things. That is, you can't find an assisted living facility in a green zone there in our community. And that, it's a stunning conclusion. So I just want to say that as you identify this and we superimpose that reality, that's a key thing for our communities to think about how they want to value that. So I wonder what your thoughts are, what you've learned about that issue.
Yeah, thanks for sharing that, Bill. I think it is so important when grappling with these conversations to think about a couple of things: how entrenched the United States is in car dependence across the board, and then also where we can build new resources and what this looks like. It makes it really challenging to come up with solutions to this, but I think it makes it nonetheless incredibly important to focus on it, because again, once we pour in concrete these decisions about what streets look like, where the resources are, how walkable these communities are, we will continue to face health inequities going forward. And so I think it's so important to show that in the research and then start to make changes now, because essentially the history of systemic racism in our society doesn't mean that we shouldn't start to do anti-racist things moving forward, even if it means that we won't see the payoff for quite some time. Yes, Val.
Hi, TJ. That's great work, and I'm really glad that you got that qualitative piece in afterwards. So 2 reflections working with the rural population. And one is that the thing that links them when they, first of all, they retire from driving later than they should. And second of all, they is their family. And so if there's any way that your database, I don't know how you can look at whether they have family around, because that's a prime driver for them. The second thing that's become more evident actually through the pandemic is that there's, from where we are down into Greene County, there's very limited broadband. So even those that still could function to the point of connecting in a way using broadband are denied that. So that's kind of another piece. Got lots of pieces you can work with. So thank you.
Yeah.
Great work.
Thank you for those comments and those questions. Yeah, I could talk about driving retirement for hours. There's so many different facets of this. So to your second point, broadband access. In the pandemic, we have definitely seen how people connect and engage change dramatically, including for older adults, but that has also been equitable for people that live in rural communities or disadvantaged communities. And to your first point about caregivers, again, in this society, we rely so heavily on informal caregiver support, particularly for the care of our older adults. And so that's absolutely an important part to include. And I think there is some information as well about those informal social supports that I would be very curious to explore further as I get into the data here.
So this is really exciting and interesting, but provocative. Let me ask you a question. Do you think that the older persons who have retired from driving want to carry their groceries from the grocery store back to their house? So it may be walkable and accessible to get to the grocery store, but do they want to carry these groceries home? With the hopefully improving broadband capacity and delivery opportunities that we've seen with COVID, do you see this as an alternative for these individuals where these delivery programs can obviate some of these deserts of walkability?
That's a great question, and I think it really gets to the purpose of the trips that people take. So, from a healthcare perspective, one of the purpose of trips that I think about is getting to the doctor's office. Another important trip for health is getting to the grocery store. And no, I don't think older adults are going to be very keen on carrying their groceries for longer distances, or that walkability might be the most apt way to address that. For some of those problems, I think, yes, having grocery delivery services, Meals on Wheels, we have some systems in place. They're not perfect. They need a lot of work still for getting people to their doctor's appointments, getting people to the grocery store. To this social isolation piece, though, it's more about where people need to go beyond that when we think about just staying connected and engaged in your community. And those kind of trips, we really don't have good systems for getting people to those with sort of, non-emergency medical transportation does not cover getting to the library for a book club. And not all of those things can be replaced with online communication somewhat. And certainly people's decisions about when and where to travel has changed in the last year and a half because of the COVID-19 pandemic and what we need to do in person versus what we can do online. I think we all feel a little bit differently about now, but we're going to be grappling with rural broadband issues as well. And so I think thinking about how we can identify the communities where people have resiliency for maintaining walking and connection to those more informal social engagements is really key for the overall well-being of older adults.
I was just sort of along that line going to just suggest you have really great graphics in your presentation. The World Health Organization Social Determinants of Health graphic puts that social cohesion in the center of that particular graphic, which I think really gets to what you were just saying, that it's more than just the walkability component, it's the social cohesion that's really critical. So I just wanted to make that suggestion to your excellent slide deck.
Thank you for that. And I think that is part of what I'm hoping to include with some of that subjective information about how do people feel about the connections that they can make and want to make within their community. So very excited. Next steps.
We can do one more.
Oh, great.
Well, we'll be a minute late then, but that's okay.
I was really glad to see the conceptual model, KJ, and I think it's coming along really nicely. I wondered what you were thinking about inclusion of health or some measure of health as a covariate, and I bet you've been around this, so I'm just curious how you landed.
Yes, I think that's also an important point. There's a lot of covariates that I could potentially include, and that is probably an important one to think about. Certainly baseline health, because that is going to be one of the important predictors for how people are making these decisions. It's complicated, and that is true of anything when we start to think about these, again, looking back at social conditions and how they interface with all of these biopsychosocial conditions for people, how we move forward from that. But that is an excellent point as well. Thank you, Elizabeth.
Excellent, excellent, excellent. PhD in the not too distant